5 p.m. Singapore time. This event is currently co-endorsed and hosted by APSC, TSOC, as well as PCS. My name is Jack, the current president of the Asian Pacific Society of Cardiology, as well as the president of the International Society of Cardiovascular Pharmacotherapy. I'm from Singapore, a practicing cardiologist, particularly in interventional cardiology. We're very privileged to have the co-host and guest today from Taiwan, Professor Lin Jun Lee. He's currently finishing up on his clinic and he will join us shortly. We're also very grateful for our 4 speakers today. Professor Shahbaz Qureshi from Pakistan, Professor Yi-Heng from Taiwan, Professor Upendra Kaul from India, Professor Akhter Ali from Pakistan. So these are our 4 speakers. And it's quite amazing that although we are caught out in the COVID times, this is a 3-city joint symposium between Islamabad, Lahore, and Karachi, with our respective co-chairpersons as well as panelists. So we'll take a moment to acknowledge our co-chairs as well as panelists from each respective city. And this webinar is currently live streamed by our APSC Facebook, YouTube pages, and Wonder Medicine. The views expressed on this webinar are those of the faculty members and do not necessarily represent the views of APSC, but we are looking forward to an exciting webinar ahead. This is a program. Each speaker will speak for 12 to 15 minutes. We're starting off in identifying the high-risk ACS patient by Professor Shahbaz Qureshi, followed by Professor Upendra Kaul, narrating to us the role of ACS and the use of Ticagrelor. Professor Yi-Heng from Taiwan then will compare Ticagrelor between that antiplatelet agent and other current antiplatelet therapy for ACS. Lastly, we'll end off with Dr. Akhter Ali, comparing Ticagrelor and other antiplatelet agents, the local experience coming from Pakistan. So without further ado, we'll get started with the first lecture, and I'll welcome our first speaker, Professor Shahbaz Qureshi. And he's going to speak to us about how to identify the high-risk patient. So welcome Prof Qureshi for his opening lecture. Thanks. Prof, could you share your slides and also unmute yourself? Prof, are you able to just change your display format to a full screen format before you start? Display setting to sort the display view, then unmute yourself, please. Under the display setting, on the top left-hand corner, display setting, click on display setting, then swap a presenter view.
Next slide. When we talk about coronary syndrome, we should understand that it actually encompasses a very broad and a heterogeneous population. It is those people who have atypical symptoms and may not be ACS, or those with atypical symptoms and may be ACS, and those who are ACS patients who can be diagnosed very easily. Next slide. So what we really need to do is to understand, we have seen this slide several times before, that when the ischemia cascade begins, normally, initially, there's a normal function which starts with a perfusion abnormality, and then you have a regional diastolic dysfunction, and then you start having wall motion abnormalities on echo, and then you can see these electrocardiographic changes, and finally it ends up in angina pectoris. So basically, what we are seeing sometimes is a time lag which takes place in these patients. And that is what actually we want to prevent, so that we can manage these patients in the most appropriate manner. Next slide. So what we need to do is to get the diagnosis. We need to risk stratify these patients, look at the clinical implications that it can have, and then monitor the therapy in these patients with ACS. And whenever you have an ST segment elevation and you have actually thrombolized them, you would see that in those patients in which the ST segment continues to stay elevated, their 30-day mortality is high. And the clinical implication of those who have benefited from thrombolytic therapy, that will reduce the mortality in these patients with a reperfusion. And then follow up, one needs to monitor these patients so that we can identify those patients who have a high risk and they have problems in the future as well. Then what we need to do actually is to see whether these patients who have the clinical probability of ACS, either they are a low probability, an intermediate, or a high probability, and then we are able to diagnose it properly. And then ultimately, we are able to identify which are the patients who are going to need treatment. Whenever we look at the electrocardiographic changes, you would see that in an acute coronary occlusion, early on, you're going to have a hyperacute T wave, which comes within minutes and hours. And if we miss this, we can miss a patient who actually will lose the muscle then. And then within 0 to 12 hours, you'll get the ST elevation, and then the Q waves coming in. And ultimately, in the later on period, you will get patients who will have Q wave and a persistent ST segment elevation. And if they are reperfused in time, you would find that the R wave is, it persists and the Q waves are not there with T wave inversions. And what we have seen over a period of time is that these T waves then reduce in depth as the time progresses in these patients. Now, everything is not ST segment elevation. And when we look at the proximal left anterior descending artery acute occlusion, and I'll show to you some cases with unusual presentation ECG pattern. For example, here in this ECG, you would see that there is a generalized ST segment depression, which you can see here, but no elevation. However, if you concentrate here on AVR, you will find that there is an ST segment elevation. And this is very typical in patients who have, yes. And you will see here that this is a proximal LAD, which has been occluded in this case, and on recanalization and after stenting this patient, you will see that the changes here have settled down with T wave inversions and Q waves. So it is as early as possible so that you can treat them in the best possible way. Now, this is the second patient where in the electrocardiogram, you will see that these are the changes which I showed to you earlier on the hyperacute T waves. And here you see that there's a proximal LAD, which was occluded just at the origin. And then with the reestablishment of the flow here, you would find that the changes here are those of Q waves with ST segment elevation. So when we look at the predictive value of ST elevation in AVR, it is extremely important to actually concentrate. This is the orphan lead or the forgotten lead. And we actually should concentrate on this. You have an ST segment elevation in AVR of greater than 1 millimeter, actually indicates a proximal LAD or a left main coronary artery occlusion. and ST elevation in AVR predicts the need for CABG in these patients. So it's very important that we concentrate on the lead AVR in our patients. Now, when we look at the after is the electrocardiogram, which plays actually the pivotal role in the diagnosis of patients with ACS and identifies the high-risk individuals, we have certain established and novel biomarkers which we must keep in mind, and the level of troponin which indicates necrosis in these patients with ACS, and it also shows those who have elevated troponin, those with myocardial infarction. It has a prognostic value, clinical implications, and then you can monitor the troponin levels in these patients with ACS when you follow them up sequentially. You have myoglobin also, natriuretic peptides, but the troponin levels are the most important. Now, when we look at the release of myocyte necrosis, this will release troponin in the blood. With inflammation, there will be a high sensitivity CRP and accelerated atherosclerosis. You will have a look at the HbA1c and blood glucose, vascular damage. Then you look at the estimated GFR and hemodynamic stress when you look at the other markers like BNP and the NT-proBNP. Now, when we look at the high sensitivity troponin levels, why do we need high sensitivity troponin I? That is very important. And then we can actually concentrate on the European Society of Cardiology guideline regarding the 1R algorithm. And the need for high sensitivity troponin I is that we do not want to miss the acute myocardial infarction. And we want to diagnose it early because time is muscle. And I go a little further and say that muscle is time because it improves the ejection fraction, and that the ejection fraction actually determines the quality of life. Next one. When we look at the conventional assay and the high sensitivity assay, we will see that the conventional actually misses 25% of all the NSTEMIs which we see. And for example, you may have a likely normal conventional assay, but this is a percentage you are going to miss in these patients. So it is very important that you use the high sensitivity troponin. The diagnostic accuracy at presentation is increased with all these high sensitivity troponin levels, and this is the conventional one, which takes a long time, and you have to wait for long to be able to diagnose your patients with ACS. So I think it is important that we concentrate now on the high sensitivity troponin levels. So how to use them? This is very important. It is not a pregnancy test, remember. It is not a positive or a negative. You have to quantify it. And if you look at the quantification of it, you would see that as the level rises, you have an increased cardiomyocyte injury in these patients. If it is very low, it has a very good negative predictive value. But it is extremely important that you want to assess the patients in the clinical setting with the symptoms and vital organs, and the electrocardiogram extremely important. Combine the troponin level with the clinical presentation, with the electrocardiogram, and the change in troponin is also very important. Then with this, you actually are able to triage the decision to rule out MI, and if the differential is with non-cardiac unstable angina, STEMI and non-STEMI. Now, when we look at this 1R algorithm, if you have a very low level of high sensitivity troponin, you can actually rule the patient out and then discharge. But if it's high, in those cases, you rule in and take the patient to the cath lab or the CCU. And these are the levels that you see in these patients where you rule out and you can discharge these patients and rule in when the level is high in these patients. Now, I present to you two case studies with a 61-year-old gentleman with chest pain 2 hours ago, pressure, a duration of 1.5 hours, and the intensity of 5/10, with a radiation to the left arm, relief of pain while lying down. there was a history of 2 risk factors in this patient with a former smoker and the level of cholesterol being high. Now, if you look at the electrocardiogram in this patient, you will find that it is normal. And if in such a case, when you see a patient with a normal electrocardiogram with that presentation, you may have the chance to send this patient home. But if you look at the high sensitivity troponin level in this patient, next slide, you would find that in this case, the level is 3 nanograms. And this is a history with chest pain for 2 hours. And this, after that, if you want to discharge the patient, you can very easily do that. So you can rule out the infarction in this patient with a very, very low high sensitivity troponin level. And you can actually, if you wish to, you can then reassess the patient after 1 hour and after 3 hours, and you can see that the levels are the same. The patient can be discharged, and in the outpatient, myocardial perfusion imaging can be performed in such a patient, because if this patient had chest pain, it is important to completely rule out coronary artery disease, and that can be done by myocardial perfusion imaging. Now, the take-home message from this case is that it would allow immediate rule out if the chest pain is more than 3 hours. And the main advantage of high sensitivity troponin level is a rapid and a safe rule out of acute myocardial infarction. This is the second case with 48-year-old gentleman. And the chest pain of 2 hours, burning duration, the intensity 9 out of 10, no medical history, a heavy smoker. Next slide. The ECG is once again absolutely normal. Next one. And when you look at the troponin levels, you would see that the troponin level is 39 nanograms. And the level you need here is 52 to rule it out. With this level, you don't rule out, you rule in for infarction. And what we should do next is we can monitor this patient for another 1 hour and 2 hours and then see, or what we can do is even with this level of the troponin, high sensitivity troponin, we can send the patient to the cath lab. This is the patient, and you can see a tight lesion in proximal LAD, which was stented, and he was all right. Next slide. Next one. So basically, in this patient, when the serial troponin levels were done after 1 hour, you can see that the levels were very high after 4 hours. So the take-home message is that the positive predictive value about 90% for patients with acute myocardial infarction, and they can be sent directly to the cath lab. Next one. Next slide. Now, once we have seen the electrocardiogram changes which can take place in ACS, then the biomarkers which can be seen here, then we can also use the different imaging technologies that we have. For example, you can have an angiogram done in patients with ACS or myocardial infarction to see the prognosis, the clinical implications. Echo can be done. Myocardial perfusion imaging is useful to find out about the old infarct and the new ischemia which is there because of the ischemic memory that these imaging technologies contain. And then we can also look at the computed tomography and cardiac magnetic resonance imaging. Next slide. Now, this is another patient. This is the role of echo in ACS. You can diagnose, you can assess the complications, the acute hemodynamic status, the post-MI risk stratification and prognostication can be done. The therapy effectiveness can be seen and the change of therapy and viability. Now, this is another case where a 61-year-old gentleman came with severe breathlessness, and his ECG, you can see there are hardly any changes there except for sinus tachycardia. And this patient was treated for acute asthma and was given the bronchodilators, etc. And then the X-ray you can see, this was the X-ray picture, but when the point of care ultrasound was placed on this patient, it was found that there was a global hypokinesia. And when and for this, after this evaluation, he was shifted to the cath lab where there was an ostial left main critical stenosis and the patient underwent angioplasty. The other wall motion abnormalities that you can see, for example, with the echo, anterior wall akinesis like an aneurysm, and in ischemic cardiomyopathy, where you can see in the inferior wall an aneurysm here, the sept and the left ventricle is dilated, and you can diagnose these patients with ischemic cardiomyopathy. Then in those patients in whom you have suspicion of coronary artery disease and you would like to do an anatomic diagnosis with them, with coronary CT angiography, you can find a mixed plaque here. Several times what I have done is that in a patient who has a normal troponin level, and I take them to the for CT angio, and I find a very critical stenosis in these patients, and that way I can triage this patient straight to the cath lab and open up that vessel. Next slide. You can also have a similar, you can assess it in by CMR also, when you can see the ischemia in this case here with perfusion imaging, and you can have some edema around it, which will show that this patient is having an acute ischemic episode. And when you have a scar, then it is like you see a late gadolinium enhancement in these patients. So finally then, what we come to is that what we need is an optimal approach, which includes a combination of clinical, which I've shown to you, the ECG, the biomarkers, and the imaging techniques. They all actually join together to make the diagnosis and identify the patients with high risk acute coronary syndrome. So what the questions we need to answer: does this patient have ACS? Should he undergo early catheterization, which is extremely important because time is muscle? And what is the patient risk of sudden cardiac death? These are the things which we need to evaluate in these patients. So the clinical need is for improved methods to diagnose, risk stratify, guide treatment and evaluation of therapy. And we need to actually be in the search for new methods where we can diagnose these patients and then submit them to the appropriate care which they need. So what I have tried to do is to try to identify those patients with ACS who are high-risk individuals. And for that, you need a good clinical judgment. You need the pivotal role of the electrocardiogram, the biomarkers, and I think now we need to shift to the high sensitivity troponin I levels in our patients, and they should be done. And then the imaging techniques that can be employed in these patients, because we are all, as I say, ambassadors of our patients, and we need to give them the best proper treatment. Thank you very much for your patient listening.
Thanks, Prof. Shahbaz. That was indeed a very comprehensive lecture, and you covered a lot of grounds there. Perhaps I can ask some of our speakers and to share their experience across the region. Dr. Professor Yi-Heng, are you online at the moment?
Yes, I'm online.
Yeah, Prof. Shahbaz covered a lot of ground from the clinical presentation of a high-risk ACS to high-sensitivity troponin T and the imaging modalities. Perhaps you can give us a flavor of in Taiwan, how do you actually risk stratify or categorize a high-risk ACS patient at the emergency department?
First of all, I think the clinical symptoms and signs are still a very important indicator of the clinical severity of the patient with the ACS. So first of all, we will evaluate patients' clinical symptoms and signs, especially for those patients with persistent chest discomfort. I think that's a very important indicator. And the second one, I think, is very traditionally still the ECG. If the patient has a very dynamic ECG change, I think it's also an indicator for the very important for the risk stratification. And the third one, of course, is the cardiac biomarker. Right now, we also use the high sensitivity troponin in Taiwan. So if the patient has a very early rise of the high sensitivity troponin, it also indicates a high risk patient. So for all those patients with evident clinical symptom despite the medical treatment and with very significant ECG ischemia changes and also early rise of the high sensitivity troponin, we send the patient to cath lab as soon as possible. So that's what we do in Taiwan right now.
Just a last comment from Prof. Lee. In Taiwan, do you use any CT angiogram modalities to further re-stratify at the emergency department?
No, usually the CT angiography is only reserved for those very low risk patients. So if you're not very comfortable to let the patient to go back to home, maybe you can rearrange the CT angio. However, this examination is only for those very, very low risk patients.
Thanks, Prof. Lee. Professor Upendra Kaul from India, are you online?
Yes, I'm online. Can you hear me?
Yeah, Prof, loud and clear. Perhaps you can also make some comments about the practices in India now. Do you do any risk scores like grade score, TIMI risk scores to classify the high-risk ACS patients at the moment?
Yeah, certainly. Most of the institutions, cardiology centers in metro cities do it, and both TIMI scores and GRACE scores. But TIMI score seems to be easier for our cardiologists. They do it very often, and anybody with a high score, they immediately go for, angiography if the troponins are high, if the ECG change is there, and if there is a multiple risk factors, they would always go for a angiography.
Prof, besides a STEMI or like what's presented, the widespread ST depression and the elevated AVR, which group of ACS and STEMI patients do you think deserve to be brought to the cath lab as soon as possible?
I think a patient who is, number one, having chest pain and persistent ECG change, has hemodynamic compromise, is getting runs of, malignant arrhythmia like runs of VT, and also if the ECG is showing, marked ST depression, 4, 5, 6 millimeters ST depression, not responding, and obviously AVR ST elevation, as Shahbaz was trying to say, has got a reasonable predictive value of severe disease like left main.
Thanks, Prof. Upendra. Dr. Shahbaz, can I just ask you, in Pakistan, what is the current practice for patients presenting with NSTEMI ACS? Are they preloaded with DAPT, or they are on single antiplatelet, started on subcutaneous therapy like Clexane and brought to the cath lab? Maybe you can share with us the practice in Pakistan.
Professor Jack, can you repeat the last couple of sentences?
No problems. In Pakistan, what is the current practice if we do identify ACS and STEMI patients? Are they preloaded with DAPT like STEMIs, or do you bring them to the cath lab early without preloading of DAPT?
I think the practice is to preload these patients and to bring them to the cath lab if they are persisting with the symptoms and the ECG changes are persistent there in these cases. And if you have the troponin levels going up, and I did try to find out if there were institutions which were doing high sensitivity troponin I levels, but at the moment, very few which are doing this. And I think that as Professor Kaul also mentioned, the TIMI score for an acute event is very useful, and we do take help from that. And the GRACE score for as a long-term prognostic value, yes, we do those scores there. But we are at the moment loading them up with the drugs which are more in conventional use as compared to with Ticagrelor or Prasugrel. They are being used less as compared to clopidogrel and aspirin.
Thanks, Prof. Shahbaz. Can I get one last comment before the next lecture by Prof Kaul from Professor Yi-Heng? We know that the ESC guideline currently advises us against preloading a DAPT for the ACS patients. But in Asia, we have heard from our colleague from Pakistan, the practice in Asia is still to preload a lot of these patients bring to the cath lab. How do you give advice to balance out this approach across Asia?
So currently we have very similar clinical practice just as our colleagues they do in Pakistan. Usually in Taiwan, we also routinely preload the P2Y12 inhibitor and the aspirin in the emergency department. So that is a very common practice right now. So basically, even the ESC guideline now changed their recommendation. However, after a full discussion right now in my country, most of the cardiologists still favor to give the patient P2Y12 inhibitor in the emergency department. However, we do consider that if the patient has a very high bleeding risk features, we will be more conservative, maybe only use aspirin first. So that's what we practice right now in Taiwan.
Thanks, Prof. Lee. So just to quickly summarize this first topic, which is very important, identify the high-risk ACS patients. It cannot be further said that the clinical features overwhelm everything else. A patient who has hemodynamic compromise is hypertensive, tachycardic, grade class 3 to 4, widespread ST depressions with raised AVR, ongoing chest pains. These are the high-risk patients. I don't think we need scores or even a high-sense troponin T to come back before you diagnose it as high risk. The high-sense troponin is useful, but the usefulness is to subcategorize a group of what we traditionally label as unstable angina into the ACS group if it's positive. And this brings us to whether the patient needs to be brought to the cath lab early. I think the current guideline do suggest that ACS troponin positive patients will benefit from an early invasive approach. The stance from Asia about preloading with DAPT is still currently quite widespread. I think the ESC guideline does give us some leeway to say that if you are using or employing an early invasive approach, then maybe you should look at the coronary anatomy before loading. But in Asia, a lot of the cath labs are not able to bring the patients to the cath lab within the 12 hours. So I think a preloading approach is still reasonable in my mind. The caveat is a high bleeding risk patients or truly the patient that should undergo CABG. You think is high risk coronary anatomy, maybe preloading maybe pose a challenge as demonstrated by trials like ISO-REACT 5. So I think we'll move on to the second lecture before we call for comments. So we would like to welcome Professor Upendra Kaul to give us our next follow-up lecture on ACS and the use of Ticagrelor.
Well, good afternoon, friends from Pakistan. Many of them are very well known to me, and obviously Jack knows me quite well. And today I'm going to talk on the role of ticagrelor in the management of high-risk ischemic acute coronary syndrome. And Shahbaz has very elegantly told us what does a high-risk acute coronary syndrome mean. Now, what I'm going to talk about is recurrent events in acute coronary syndrome, patients who are diabetics, patients who have multiple coronary artery disease, and also what about its role after 12 months, because it's a ongoing process. Patients of acute coronary syndrome don't become very stable for years to come, and one has to think about their future also. We also would like to look at, does ticagrelor give any mortality benefit? And finally, what do the guidelines say today? Now, let me start with a case. Is a history of the patient, a 65-year-old gentleman. He is a smoker, overweight, has many risk factors. He was a hypertensive, hyperlipidemia, diabetic, but well controlled on medical treatment. He underwent PCI of the left circumflex and LAD many years ago in 2005. 7 years later, he had again ACS with unstable angina, and this time he was again treated with a drug-eluting stent in a different portion of LAD, and then dual antiplatelet therapy consisting of aspirin and clopidogrel was started. And as is done, and also the guidelines tell us that the second drug, which in this case was clopidogrel, was discontinued after 1 year, and aspirin was continued. This time he presented to us 2 weeks ago when he came with a 2 hours history of chest pain and came to the emergency department. His blood pressure was 100/68. His heart rate was 86. ECG showed telltale ST elevation myocardial infarction. His initial troponin was modestly high, but eventually it rose to severely high levels. He was quite stable. He had some pain, but at the same time was quite comfortable. His creatinine clearance was reasonable. He had a total cholesterol of 136. He was already on a high dose of statin, LDL of 78, which we know is higher than what we want today in such patients. And his high density lipoprotein was okay. As per the TIMI score, it was risk score was 2 and his GRACE score was 82, 2% mortality for admission to 6 months. Now this is the ECG showing a marked ST elevation and some reciprocal changes. He was taken to cath lab, as was seen by the total clinical picture, which showed a complete occlusion of the proximal segment of the left anterior descending. So the problems in hand are patient with the multivessel disease, although many of the vessels had been treated earlier. He presents with acute coronary syndrome with a reasonably well-managed diabetic status, hypertensive, and a dyslipidemic. Obviously, he needs to be taken to the cath lab, and a primary PCI was done. Well, as soon as he was taken to the cath lab, we know whether he should be given again a loading dose of clopidogrel or ticagrelor. Today, we have large body of data suggesting that ticagrelor is superior to clopidogrel in this situation, and the Plateau study, which was a large study done in 43 countries with more than 18,000 patients, comparing clopidogrel with ticagrelor, clearly showed that ticagrelor was better in the short term and also up to 1 year. As you can see that within 30 days, there's an absolute risk reduction of 0.7%, relative risk reduction of 12% with a hazard ratio of 0.88, and after 30 days, the hazard ratio reduction is still persisting, is 20% reduction, in fact, even more than what happens in 30 days. So obviously, the data today suggests that ticagrelor is better than clopidogrel. We have similar data from prasugrel also in the TIMI-Triton study, where bleeding was an issue, which was more than in ticagrelor. We're not going to discuss that part. Maybe we can take it in our discussion. So now he underwent an angioplasty, and now his ejection fraction was 46% after discharge. Obviously, he was treated in time. What about the future after a successful PCI? Obviously, he was treated with evidence-based medicine. He was on ARNI, beta blockers, aldosterone antagonist, very high dose of lipid-lowering agents. Being a diabetic, he was on SGLT2 inhibitors, and many of us might like to put him on a GLP-1 analog also. He was obese and he had, past myocardial infarction, and we know that vascular events are significantly reduced by drugs like liraglutide, which are available, are expensive, are injectable. Now let us come to looking at the future. Now we know that as per the Apollo 4-country registry, 16 to 20% of patients are going to develop death, myocardial infarction, or a stroke in the subsequent 3 years. And this is very well known. Similarly, if we look at the Swede Heart study, it's very clear that it's not only the culprit vessel which is important. In fact, the non-culprit vessel seems to be more important than the culprit vessel for the future events. And sometimes it is difficult to find out which was the culprit vessel in the long run. So it's always very important that we do something so that the vessels, other vessels are also passivated so that they don't get involved in future acute coronary syndrome events. And this is what the prospect study of 2011 tells us, that culprit lesions are more frequently involved in the events as compared to non-culprit vessel lesions. As you can see here, 12.9% versus 11.6. And if you look at all the events, they're much more frequent in the non-culprit vessels. Now we know that platelets are extremely important players. There are many players, but platelets are very important players involved at all the stages of atherothrombosis. The platelet adhesion in the initiation and progression, it releases inflammatory mediators, cell recruitment. Activation of the platelets leads to inflammatory mediators and plaque instability. And finally, the platelet aggregation leads to the final event, non-ST elevation MI or ST elevation MI, with a thrombus formation, complete occlusion versus a uh, incomplete occlusion. Now let us look at what is the role of ticagrelor in patients with type 2 diabetes. We know that this large study, Plateau, had a large number of diabetics. So let us look at that subset. If you look at other trials, we can see that diabetics always have a higher chance of getting a cardiovascular event like death, myocardial infarction, or stroke as compared to non-diabetics, whatever way you look at. If it is 16.9% in non-diabetics, it is 26% in the long run up within 3 years. REACH registry shows the same thing, that diabetics with known atherothrombosis have, with prior ischemic events, have a highest role. And if the patient has only risk factors, they have a less chance of getting a vascular event in the future. Now, diabetes, how does it affect antiplatelet agents like clopidogrel? As Shahbaz was saying, that clopidogrel is still one of the very commonly used agents, even in high-risk acute coronary syndrome in many countries, including Pakistan, and I would say in many parts of our country, India also. Now, if you look at diabetics versus non-diabetics in the acute phase treatment, you would see that in diabetics, about 30% of the patients are not responsive versus 8% in non-diabetics. That means significantly higher percentage of patients not responding. And poor responders, again, higher in non-diabetics. And you can see it's 6%. That means diabetics have a higher chance of not responding to clopidogrel. Only about half of them are responding, whereas about 3/4 in non-diabetics are responders. That means the platelet inhibition is more than 30%. In the long run also, if you look at by ADP provocation, whether you give smaller doses or higher doses, the platelet aggregation is significantly higher in diabetics as compared to non-diabetics, as can be very clearly seen in this study by Angelin, which was, a study done about 15 years ago. So if one has to summarize, diabetics have increased platelet reactivity compared with non-diabetic patients. Those who are treated with insulin have a higher platelet reactivity compared with those not receiving insulin. And compared to non-diabetics, patients have a higher on-treatment platelet reactivity in diabetics, and they have worse clinical outcome. And a number of risk factors might be responsible for this poorer response to clopidogrel in diabetics. It could be whether we can use higher dose of clopidogrel. We don't have a consensus on that, but most data suggests possibly it doesn't work very well, and whether we should be using something else. So what are the strategies to enhance P2Y12 inhibition in diabetics? Increasing clopidogrel dosing, give them 150 milligrams or adding agents that modulate intraplatelet therapy. That means you give something else like silastazole. It used to be popular. So sometime, especially I think in Korea, it used to be given in larger number of patients, high risk patients, stent thrombosis and other things. Or we can use the novel potent P2Y12 inhibitors, which are very freely available now for the last, I would say, more than 8-9 years, both ticagrelor and prasugrel. Now, if we look at the plateau sub-study, of the more than 18,000 patients in the diabetic subgroup, you can see 96% of diabetic patients presented with type 2 diabetes. And whether the diabetes was well controlled, that is HbA1c 6 or more than 6, it really did not make much difference. And as you can see, that ticagrelor versus clopidogrel in diabetics, it was clearly superior in terms of reduction in cardiovascular death, MI or stroke. You can see 14.1% with ticagrelor versus 16.2. And you can see it's very significant difference. And the same difference which was seen in non-diabetic. So that means the diabetes, in addition, is not attenuating the effects of ticagrelor. What about bleeding, which is always a cause of concern, an issue? With more potent drugs, you expect more bleeding. But what about ticagrelor in this situation? You would see that there is hardly any difference in diabetic patient population between clopidogrel and ticagrelor, both around 14 to 14.8%. Same was seen in non-diabetics. So not very different. So if we have to summarize the plateau diabetes sub-study, the efficacy of ticagrelor is consistent with that observed in all through in the plateau study, whether you look at death, MI or stroke, and there is no definitive efficacy conclusion between treatment groups. Although the groups which have been subdivided are smaller in sample size, but this could be hypothesis generating. And there is no significant increase in major bleeding also. So efficacy seems to be maintained without any extra cost of bleeding. Now we're very clear that ticagrelor is superior to clopidogrel for the management of acute coronary syndrome, whether the patient goes for PCI or the patient remains on medical treatment, because there's a large arm where the patient did not go for immediate invasive treatment. But what about after 1 year? Because the risk is continuing to be there, and that is the PEGASUS study, PEGASUS-TIMI 54 study, which came in 2016, and it shows that, first of all, it showed that ticagrelor 60 and 90 had the same efficacy, but as expected, the smaller dose had lesser bleeding. So we're talking about 60 milligrams as compared to placebo. Aspirin was common. Now you can see that cardiovascular death, MI, strokes are clearly lower. If we look at the hard endpoint of cardiovascular death, there's a 26% reduction in cardiovascular death. And if we look at coronary heart disease death, there again is about 36% reduction in the coronary heart death. So it's very important that both the things are reduced. The reduction in myocardial infarction and stroke, if we take separately, is not so impressive as is cardiovascular death and coronary heart disease death. What about safety? Obviously, if you are combining other antiplatelet agent, which is very effective, more effective than clopidogrel, you are going to have more bleeding. So same was seen even with 60 milligram dose. TIMI major bleeding is higher than placebo, and TIMI major or minor bleeding is also better with the placebo arm. But if we look at fatal bleeding or intracranial hemorrhage, is not different, and all-cause mortality is not different, indicating that there is a cost of bleeding, but that bleeding can be managed. It is not leading to increase in intracranial hemorrhage, which everybody is very scared of, and also no difference in the all-cause mortality. So if we look at the efficacy and safety, we see that the cardiovascular death, MI, stroke is significantly reduced, cardiovascular death is reduced, Myocardial infarction is not significantly reduced, stroke is reduced, all-cause death is not reduced, coronary heart disease death is reduced. Safety, if we look at TIMI major and TIMI minor bleedings are more in the ticagrelor group, as would be expected also with a potent drug on board, but that is you know can be managed. It does not lead to mortality. So the diabetic analysis clearly shows that bleeding is manageable, and evidence of Plato and Pegasus trials to us suggests that patients with diabetes who suffer a MI may derive particular clinical benefit in the long run. After 1 or 2 years of the acute coronary event, the benefit is still there. So, what about the role in patients with multivessel disease or extensive coronary disease, as our patient had from 15 years history? You can see that mortality of triple vessel disease, howsoever it is treated, is always significantly higher than double vessel disease and single vessel disease. As you can see, it is 7.8% versus 3.2 to 4%. Triple vessel disease, 1 year death being significantly higher. Whether it is ST elevation myocardial infarction or non-ST elevation MI, the story remains the same. Multivessel disease over a long period of time has a significantly higher mortality than single vessel disease. And even for non-ST elevation MI, the story remains the same, that the mortality is higher. So patients with multivessel disease had always significantly greater mortality. If we look at the sub-study of Plato, where we divide or dissect them into left vein disease, triple vessel disease, and patients with prior CABG, which again is usually multivessel disease, 30% of the patients in Plato had multivessel disease, and they were less likely to undergo PCI, but more likely to undergo bypass surgery in this situation. That also we know. Now we can see that extensive coronary artery disease, clopidogrel versus ticagrelor. Ticagrelor is faring better with more reduction in cardiovascular death, MI or stroke, 14.9% versus 17.6, a 15% reduction. And in the patients who do not have extensive disease, this difference is not very significant. So patients with extensive disease, the benefit is also significantly more. And if we look at the mortality multivessel disease analysis, you would see that the placebo arm, the multivessel disease, is associated with higher MACE, coronary events are higher, and ticagrelor in the lower dose of 60 milligram twice a day reduced the risk of major cardiovascular events very significantly, and also coronary events, including a reduction in the coronary death, which is again, I think, a very gratifying fact. Coming to the mortality benefit for ticagrelor, we know that none of the other antiplatelet agents before ticagrelor came had actually shown a mortality benefit over and above aspirin. And here you can see that cardiovascular death is clearly significantly reduced when you compare to clopidogrel, 4% versus 5.1% with clopidogrel. Stroke, the reduction is not so different. For myocardial infarctions, the difference is significant. 22% reduction in the late or all-cause mortality with ticagrelor, and this is to be noted, importantly. So significant reduction, as you can see, as compared to ticagrelor. Ticagrelor does it much better than clopidogrel. So irrespective of the initial treatment state, whether you go with the initial invasive therapy, which was done in about 60% of patients in the Plato study, or you go with initial conservative therapy, or you go with bypass surgery. Many of our patients with multivessel disease go for bypass surgery or difficult anatomy. This cardiovascular mortality benefit is always there, and this is a very, very important fact. So we can say that ticagrelor had significant reduction in cardiovascular mortality at the end of 1 year. But will ticagrelor reduce mortality beyond 1 year post ACS? And this is, one can see in the PEGASUS study, that there's a significant reduction in cardiovascular death even in the longer periods of time after 1 to 2 years of acute coronary syndrome. Very significant reduction of about 26%, very prominent here. And as you can see that coronary heart disease death is also reduced by about 36%. Myocardial infarction rates are not reduced, stroke rates are not reduced, but death is reduced. So the current guideline clearly tells us that DAPT beyond 12 months, 2016 ACC-AHA guidelines and 2017 focused update on DAPT, which was the last to come before the, our this pandemic. It is basically a class 2 indication, but a class 2B indication. That is ticagrelor 60 milligrams twice a day is the only P2Y12 inhibitor recommended and may be considered up to 3 years. And same continues in the European Society focused update on DAPT with a level of evidence B that it is preferred over prasugrel and clopidogrel in patients with prior MI and high ischemic rates and may be considered for up to 36 months. So if we have to look at the other data also, I know this is a ticagrelor symposium. We know that clopidogrel, prasugrel, ticagrelor, and we have a new friend, low-dose rivaroxaban, 2.5 milligram twice a day. And this is not the topic of discussion today, but we can't sleep over it. We know that post-myocardial infarction, more than 1 year, with multivessel disease, diabetics, and many other things, impaired GFR or, heart failure, which is stable, there's a significant reduction in mortality, all-cause mortality, and which is very impressive. So this also always has to be kept in mind. So with that, I think we have to be very thoughtful. We always, when a patient is given dual antiplatelet therapy, should never repent that this is my fault. If the patient comes with bleeding, we feel that this was my fault. If had I not used this particular agent, possibly he won't have bled. But one should always think that if I have used this, it's not his fate that he had to have a stroke or MI. We can actually reduce death, strokes, myocardial infarction by addition to aspirin. So I think that is where I want to end my talk today. So very important to overcome this therapeutic dilemma. And we are sitting here today to discuss how to overcome this therapeutic dilemma. Thank you very much.
Thanks, Upendra. That was, again, a very comprehensive talk, and it's a keynote speech for today because the focus today is on ticagrelor and ACS. So now I'd like to call upon my co-chairs and panelists to raise questions if they have and comments. Our co-chairs and panelists from...
Dr. Jack, I
Yes,
am Abid Amin. I have a question and a comment as well. Are you listening to me?
Yes, we can hear you clearly. Please go ahead.
Very clearly.
Yeah, the question is that there was a study by Rukhsana Mehran from ACC, though there was a smaller population in that group of study, that they used ticagrelor without aspirin and compared it with clopidogrel and aspirin. And they got a good result regarding the prevention of cardiovascular events, stroke, and total cardiovascular death. And the bleeding was also lesser in the only ticagrelor group as compared to the DAPT. So I would like to hear from Dr. Kaul his comments on this.
Yeah, I think it's a very topical question. And I was, in fact, one of the lead investigators with Rukhsana Mehran. I was looking after the data from India. Actually, that was not a comparison with clopidogrel. That was also not only a study of acute coronary syndrome, that was a study of complex coronary artery disease with multivessel disease, lower EGFR, and maybe. And for first 3 months, all of them were given aspirin and ticagrelor. And those patients who did not have any problems in the first 3 months, if you had bleeding or something, then you get away from that study. Those patients who had no problem, they were continued, and after 3 months, aspirin was dropped. And the study, which was powered for bleeding, clearly showed that there was a substantial reduction in the bleeding events. Although efficacy remained same, study was not powered to look at that, but there were no higher events of ischemic event in that. So that's a very important study, and we do follow that, but that is necessarily not an acute coronary syndrome study in which still the recommendation says that you give it for 1 year. Although people are going to 6 months now in some of the groups, but the recommendations still continue to be the same.
Thank you very much.
Excuse me, Dr. Haroon Babar here from Pakistan. Very expectations from both Professor Kaul and Professor Shahbaz. I would just like to ask one point about prasugrel. No doubt, ticagrelor has been included in the guidelines as one of the first-line agents with aspirin in primary PCIs in patients with acute MIs, either non-ST or ST segment activation MI. But in diabetic patients, the prasugrel study done way back proved that it was superior to clopidogrel. There is no comparison at the moment, and there is no study, I think, has been done to compare it with the ticagrelor in these patients. If there is, we would like to hear your expert opinion.
Well, in the TIMI-TREATON study, which was acute coronary syndrome study, it was comparison of prasugrel with clopidogrel. It was not a diabetic study, but it had a significant number of patients of diabetes, which you would have in any population. As a population, total population, it showed that in terms of efficacy, they were equivalent, but there was concerns regarding bleeding. There was a significant increase in the bleeding. If you took away 3 groups, which was post hoc, that is people, lean patients, people who had a history of a stroke in the past or TIA in the past, and I think something else also. There are three criteria. There, the bleeding events were lower. Diabetic population, the diabetic subset of that did show a significant benefit, but that was again a hypothesis generating study. Once again, a head-to-head comparison has been done recently in a few studies, and one of the most cited studies for that is from Germany, Adnan Kastrati's group, which came last year, one of the ESAR studies, which again showed in acute coronary syndrome that prasugrel was found to be superior to ticagrelor. The study has some criticisms associated with it, 2-center study, and the timing of the drugs. Ticagrelor is given beforehand, clopidogrel, the prasugrel is given after seeing the anatomy and all those things. But certainly, it has led to some kind of a resurgence in the use of prasugrel, at least in many centers in our country, because prasugrel has been a generic drug in our country for quite some time. It's cheaper. Ticagrelor has also become generic in the last 1 year, but still it is more expensive than prasugrel. And ticagrelor is always a twice a day drug, which always has its problem. Plus, dyspnea associated with ticagrelor is not seen with prasugrel, which was seen in about 20% of patients in the original study. We also see in about 8 to 10%. And sometimes it becomes difficult to differentiate that dyspnea from left ventricular failure dyspnea, because many of these patients are also having a compromised left ventricle. There are methods of differentiating it, but those are the things. So prasugrel certainly is not a drug which is gone. It is there.
Sorry, you're muted from Lahore.
Hello. Professor Kaul, thank you very much. Dr. Haroon here again. The other point I wanted to ask is ticagrelor also works by the mechanism of increasing the adenosine levels.
Yes.
And there are the dyspnea may be related to that
Yes.
process as well. So what's about how you treat that problem? Because it's 10 to 15% of the population may be getting dyspnea. Or is it self-limiting?
Well, number one, patient counseling is very important in that, telling the benefits of the drug. Number two, one can have, different ways of treating it. In the worst case scenario, when you're not sure, there's a thing called drug holiday. You stop it. If you stop it, the dyspnea goes away. You re-challenge it, dyspnea comes again. This dyspnea is because of ticagrelor. And then if the patient is not accepting this dyspnea, it is interfering with his life, obviously you go back to clopidogrel, or if you want prasugrel, if the bleeding risk is low. So that is one of the ways. And because patient doesn't understand ADP and other things, he is bothered about his dyspnea. And you have to somehow make sure that he continues it and continues it for a long period of time.
Professor Kaul, this is Dr. Bilal from Lahore again.
Yeah.
How are you? It's good to see you again, and you look as young and hearty as always.
Thank you very much.
And you're all commenting that, it's been seeing you for some time, and it's always great. Currently, there is this trend coming up regarding the type 4 infarctions that when you're doing something, and ticagrelor has not, as far as elective PCI is concerned, is not really taking off as far as that is concerned. As far as primary is concerned, yes, it is the one which is there. What is your take on it? That something which is very good as far as primary is concerned, but when it comes down to elective PCI, it's not really preventing the type 4 infarctions. So
you mean the infarcts which are related to the procedure, isn't it? Procedure-related MIs. Well, procedure-related MIs have become very important. Whenever you publish a paper or something like that on this thing, stent versus stent and all that, this is taken into consideration because they say infarct is an infarct. And, CKMB still is one of the standards for troponin has also come in there. So that's a procedural infarct, and I don't think any particular antiplatelet agent is shown to have a lower chance of that. It is, I think, the stents, the lower thickness stents which do not require such a very high pressure dilatation with 18 atmospheres, 20 atmospheres. They expand at 8 atmospheres, and you don't have to do that. You have that stent boost and unnecessary post dilatation not, then you will reduce it. And obviously side branch protection and keeping a wire in the side branch, all those things matter. But certainly one should avoid CK-Hemp bump, which used to be called. In the long run, it has been shown that it is important to minimize it, and that is procedural usually.
And one more thing that, you have this lovely slide showing that the patient is on 90 milligrams twice a day for a year, and then you can sort of taper it down to 60. What is your take on the newer trend which is coming up, 90 milligrams BD for 1 month, and then you go down to clopidogrel?
Well, there has been a study, a small study, in which they could do it. It's a small study presented and also published in European Journal of Cardiology, that after 1 month, which is the maximum period of ischemic complications, and also, after 1 month, ischemic complications reduce, you go back to clopidogrel and you get the same result. But it has not been tried and tested in a very large number of patients and still hasn't come in the guideline. But certainly if patient is a high bleeding risk, we have given it, and there is some indication that he may not tolerate it, I think it makes sense. You can try that, but have to be careful in monitoring the patient.
Last question is regarding the use of this medicine as far as the peripherals are concerned, especially with the carotids. What is your take on that?
For peripheral, say it again.
What is your take on this medicine's use as far as peripheral angioplasty is concerned, especially because there's a lot of ballooning only going on? And in carotids, how do you find this over there? That how do you think is that? Because usually bare metals are being used now.
Yeah, very large vessels usually do not need such a intensive antiplatelet therapy as coronary arteries, which are medium sized, 2 millimeter, 3 millimeter. Carotids are 8 millimeters, 9 millimeters, femorals, and again are very large. So in that situation, I think a dual antiplatelet therapy for a reasonable period of time with clopidogrel is good enough. And if you again have this bleeding concern, just take them on aspirin alone. If you are not stented, if you are stented, I would rather continue clopidogrel for reasonable period of time with aspirin.
There is a question from the audience, Upendra. Do you see any incidents of thrombocytopenia with ticagrelor?
Well, we do see, but I think I won't have the percentages, but it's very small, very small. In fact, I have stopped looking at the platelet counts during the follow-up of these patients. They never come. They do come with the purple patches, but their platelet counts are normal. We do look at those patients, and those are the patients where we take, that stoppage of aspirin after 3 months in Roxana Mehran study, uh, you know, helps those particular patients. You don't get those purple patches at least.
Thank you. I think later on, Prof. Lee would then contrast ticagrelor with the other antiplatelets. So I'd like to quickly give my comments and a brief summary for Upendra's talk. I was surprised that he didn't present Twilight, for which is a co-investigator. So I'm surprised about that. Just to recap on Twilight, Twilight patients are not all ACS patients. They are high-risk PCI within Twilight. And you do have to tolerate DAPT for 3 months before you taper down to a ticagrelor monotherapy. Roxana Mehran and Upendra Kaul's study for Twilight have the primary outcome of bleeding rather than ischemic events as a primary outcome. So we have to take a caution to that. And when you stop aspirin and you take off antiplatelet or anticoagulant, you're going to have less bleeding. So we have to be quite cautious about widespread use of de-escalation for ACS patient because it's not an ACS cohort. Although in Roxana Mehran's Twilight sub-study, it is quite well demonstrated that just ticagrelor monotherapy was as efficacious on evivial platelet aggregation studies as the DAPT with ticagrelor and aspirin. So it gives us some reassurance that for the high bleeding risk patient, I think it's a suitable strategy, but not as routine. The comment about using a ticagrelor in PAD patients, in a lot of registry, especially in the East Asian, Korean, Japanese studies, we do note that peripheral arterial disease is a predictor for bleeding as well in the subgroup. So we have to be cautious about using it for PAD indication. Yeah, so I think those. Okay, so I think I want to just recap to say that ticagrelor is, together with prasugrel, the preferred third generation thiopyridines for indication for ACS, especially STEMI, because of the faster onset. So we should use it as a primary therapy. When it comes to the questions that was brought out that causes confusion, we're talking about de-escalation therapy. I think currently we have to balance against the risk of ischemia versus bleeding. So the minimum duration post-ACS, I feel, is still between 1 to 3 months. It shouldn't be shorter than 1 month if we're employing a PCI strategy, I think, at the moment. So without further ado, I'm going to call upon Professor Lee to deliver his contrasting lecture on the other antiplatelet agents for ACS in contrast to ticagrelor. Prof. Lee, please.
Thank you. Jack, can you hear me?
Yes, clearly. Please go ahead.
Okay. Good afternoon, ladies and gentlemen. Thanks for inviting me to join you online for this very interesting symposium to discuss about the ticagrelor used for ACS patient. My assigned topic is to discuss a comparison between ticagrelor with other anti-platelet treatment in next 10 minutes. This is my disclosure. I think basically if we compare with the ticagrelor with the other P2Y12 inhibitor, the basic pharmacological mechanism are different between these drugs. So basically the chemical structure is different. If you can see that here, the clopidogrel and the prasugrel, they are cyanopyridine. However, ticagrelor is not cyanopyridine. It's a different, very different chemical structure. The inhibition of platelet activation is also a little bit different. Ticagrelor is only have a reversible effect. However, the prasugrel and the clopidogrel, they do have an irreversible anti-platelet effect. So you can see that if you use the ticagrelor, it can have a rapid onset, rapid off effect. That is due to if you take ticagrelor, it has anti-platelet effect. If you stop ticagrelor, the anti-platelet effect rapidly go away. Another important difference between this drug is that ticagrelor is itself is an active drug, not like the clopidogrel. Probably you know that clopidogrel is a prodrug, and the clopidogrel need to be metabolized in the liver and become an active compound to become the anti-platelet effect. So that is why the onset of effect of ticagrelor is much more rapid than the clopidogrel, only about 20 to 30 minutes to get the anti-platelet effect. How clopidogrel, you probably you have to wait for several hours to see the anti-platelet. So basically, the pharmacological effect is different between these P2Y12 inhibitors. So although my previous speaker, the Professor Kaul, has mentioned the phase 3 trial to compare with the ticagrelor with the clopidogrel, the very famous Plato study showing that the ticagrelor has a better clinical effect than clopidogrel in patients with the ACS. However, the bleeding risk, especially the minor bleeding and the minor and the major bleeding risk, is still higher in patients with the ticagrelor. So bleeding is always a concern for cardiologists, especially in this region, in the Asian Pacific region. Is still a major concern for us to consider to be used in our patient. So this is another RCT trial which was performed in Korea. That is, our Korean colleagues, they want to see if the ticagrelor do have a higher bleeding risk than the clopidogrel. So they performed another clinical trial which was published in 2019. This is a much smaller scale. You can see that in one arm, they randomized the ACS patient into the ticagrelor, about 400 patients. In the other arm, they used the traditional clopidogrel. In the other arm, around 400 patients. In Ticagrelor trial, the primary endpoint is the bleeding. It's a clinically significant bleeding. So you can see that in East Asian patients, like in Korea, you can see that the bleeding risk is really higher in patients with ticagrelor compared with the clopidogrel. However, what more important is the efficacy endpoint. You can see the overall efficacy endpoint. There's no significant difference between the ticagrelor and the clopidogrel in the major adverse cardiovascular event. However, I have to say that because the scale, the patient number is very small in this clinical trial, so it is hard to say there's any difference between the MACE rate between the ticagrelor and clopidogrel. However, this clinical trial do demonstrate that the bleeding risk is really higher, especially for the Asian patient if you want to use the ticagrelor. However, in this clinical trial, they don't have, they do exclude some high-risk patients, like the patient with ESRD, and for those patients with active bleeding. However, there's no limitation about age and the body weight in this clinical trial. So in the Ticagrelor trial, about 15 to 20% of their patients are older than 75 years old. and about 5 to 10% have the body mass index less than 20. So that's I think it's a major limitation of the Ticagrelor study. So in Taiwan, this is our guideline. So in our guideline for ACS, we still suggest to use the Ticagrelor as the first line treatment for ACS patient. Ticagrelor is still preferred to clopidogrel in our guideline. However, we have another recommendation in our guideline. That is, if the patient has increased bleeding risk features, we suggest to use clopidogrel instead of ticagrelor or prasugrel as the first line treatment. So we suggest to our doctors, if the patient are old, has low body weight, have anemia or thrombocytopenia, the patient has CKD or need the concomitant use of OAC, or a patient has previous major bleeding history like the ICH or severe GI bleeding history, we do recommend to use clopidogrel instead of ticagrelor. So that is the current recommendation in my country right now. So under such recommendation, we perform an observational study in Taiwan to look at, to compare the effect of clopidogrel with the ticagrelor. So this is a retrospective observation study. We, from 2012 to 2014, we included a patient with the acute myocardial infarction and observe the patient treated with ticagrelor or clopidogrel and compare their clinical outcome, including the ischemia outcome and the bleeding outcome. So we use the propensity score to match the two group of patients. So in one arm, about 20,000 patients with clopidogrel. In another arm, about 2,000 patients with ticagrelor. So you can see the primary outcome is the ischemic outcome, is the composite endpoint of all-cause mortality, myocardial infarction, or stroke. So overall, you can see the ticagrelor under such treatment in Taiwan still have a better clinical outcome compared with clopidogrel. So in our study, you can see that the ticagrelor have another 20% relative risk reduction of the total composite ischemic outcome, including the mortality, MI, and stroke. For the bleeding outcome, so this is a retrospective observation study. We only look at the severe bleeding, that is the ICH and the major GI bleeding that need admission. So you can see that here, the red color here is ticagrelor, the blue color here is clopidogrel. There's no significant difference between those patients with severe the ICH or the major GI bleeding between treated with the ticagrelor or clopidogrel. So in Taiwan right now, the ticagrelor is our first line treatment for patients with ACS. But if the patient do have high bleeding risk features, we do recommend clopidogrel instead of ticagrelor as the first line treatment. So how about the ticagrelor compared with prasugrel? So the Professor Kaul just mentioned that there's one randomized controlled trial, that is ISA-related 5 trial, which was published 2 years ago. So this clinical trial compared the effect of ticagrelor versus the prasugrel in patients with the ACS. On the left panel here is the primary ischemic endpoint, including the death, MI, and the stroke. You can see in this clinical trial, the red color line here is ticagrelor, the blue color line here is the prasugrel. It seems that the prasugrel patient treated with prasugrel had a relatively lower risk of the ischemia outcome compared with ticagrelor. For the severe bleeding, that is the BARC type 3 to 5, the severe bleeding, there's no significant difference between the ticagrelor versus the prasugrel. So this clinical trial favor to use the prasugrel as the first line treatment. However, this is only one of these clinical trials. There are other many clinical trials and the observation study to compare the prasugrel with the ticagrelor. So recently, there is a very good meta-analysis to compare with the ticagrelor versus the prasugrel. So you can see the right panel here is the two drugs result. So actually, if you put all those clinical trials and observational studies together, you can see that there's no significant difference between the ticagrelor versus the pressure graph. So ladies and gentlemen, that's my conclusion, a very short review of the comparison between the ticagrelor with clopidogrel and the pressure graph. So basically, I think the ticagrelor is still the first-line treatment for the ACS patient. For ACS patient with high bleeding risk features in Taiwan, we do suggest use clopidogrel instead of the ticagrelor. So I think our data demonstrate that judicious and the careful use of ticagrelor can bring better clinical outcomes than clopidogrel for the ACS treatment. And personally, I believe that the ticagrelor and the pressure graph have similar clinical outcome. Thank you very much for your kind attention.
Thanks, Prof. Lee. Again, a very short and succinct lecture. Can I ask my co-chairs and panelists if there's any questions for Prof. Lee? So, Prof. Lee, if I may ask, what then is a current practice in Taiwan? Is it still a predominant ticagrelor or prasugrel first strategy?
Recently, we have a very short survey here in Taiwan. Up to 2016, total overall ACS patients, around 60% of them were treated with ticagrelor during hospitalization for ACS. The other 40% were still treated with the clopidogrel. For STEMI patients, around 80% of STEMI patients were treated with ticagrelor during hospitalization. And for non-ST elevation, around 40 to 50% were treated with ticagrelor.
Thanks. There's a question from the audience. Post-CABG, is there any added benefit of using ticagrelor over other agents?
You mean the patient need CABG after the
Yes, post-CABG.
Actually, just like the Professor Kaul have mentioned, the Plato study, they have a sub-study for the CABG patient. So for CABG patient, the ticagrelor still carry a clinical benefit than the clopidogrel.
But again, it's the post-ACS subgroup, post-CABG. Yeah.
In Plato study, it's a ACS study, so they have a sub-study for the CABG patient. So,
any comments for Prof. Lee or questions? Sorry, you're muted. Maybe you can unmute yourself first. Sorry, you're still muted. You have to unmute yourself. So we'll wait for you to be unmuted first. Yeah, now you're unmuted.
This is Dr. Naman from Lahore. I guess just a follow-up on your post-CABG patients, we are hoping the Plato trial that we see less bleeding because of its offset within 72 hours, less than what you would typically see with critical patients with a shorter half-life. Excellent talk. I think the judicious use is the key word. With the Plato trial, the take-home message was that you would decrease in ischemic endpoints, stent thrombosis, and MI mortality, all those good things without increase in major bleeding. But that was for post-CABG related patients. In non-CABG related patients, the bleeding incidence was higher. And on follow-up in popular age and registry data, all that you see in those elderly patients, you do have higher bleeding with ticagrelor, and that is a problem. So I think judicious use over is the key. Just with the local population that I see over here, the aspirin use sometimes post-ACS is still higher than 100 milligrams. And I think that is a problem with ticagrelor use, as we all see. In US, it took them 4 years to get FDA approval after 2009 publication to get ticagrelor approved because they couldn't find the benefit with ticagrelor because the thought was it's probably a little higher aspirin use with that whole hypothesis that with the 80% inhibition that you get with ticagrelor, the aspirin inhibition that you need is no longer needed more than 100 milligrams of thromboxane inhibition, and the additional prostaglandin inhibition results in possible endothelial dysfunction, whatnot. So that's might be the reason that you're not seeing the benefit with higher aspirin dose. So any comments on that? Because still I see aspirin being written more than 100 milligrams post ACS, even in patients where ticagrelor has been advised.
Thank you very much for that comment. And any other questions from?
Yes, sorry, Dr. Yi-Heng, I would just like to add further to Dr. Noman's question and suggestion as well. What I read was, and what I went through was that if you increase the dose of aspirin above 80 milligrams, then there is an effect on the efficacy of clopidogrel. What would you say about this? Sorry, about the efficacy of ticagrelor.
Sorry, I didn't catch the question properly.
If you increase the dose of aspirin above 80 milligrams, along with ticagrelor, there is an effect in the efficacy of ticagrelor. What is your expert opinion about this?
Probably, do you catch the question?
Sorry, did you hear me? I'm Dr. Haroon Babar here from Lahore. Can you hear me, Dr. Lee? No?
It's a bit muffled. That's why we can't quite hear you clearly. So sorry.
Can you hear me now, please? Yes. Hello?
Yeah, can you try again?
Yes, can you hear me now?
We can try. It's a bit muffled, but go ahead.
Okay. Now can you hear me?
We can hear you. Please say it again, please.
Yes. Is it okay now? I just want, what we are asking is that if we increase the dose of aspirin above 80 milligram, along with ticagrelor, there is an effect on the efficacy of ticagrelor. We wanted your comments on this.
Correct me if I'm wrong. You are asking increase the dose of aspirin, right?
About 80 milligram, along with ticagrelor, is there an effect on the efficacy of ticagrelor? This is what we want to be explained. And how much is the effect?
Actually, can I hear you only?
Actually, Jack, I cannot hear the sound very clearly.
Yeah, so I suspect the question is if we have a high dose aspirin, does it antagonize action of ticagrelor? Is that correct? So if you give, so if you're giving above 75 or 81 milligrams aspirin, maybe 200 milligrams aspirin, does it antagonize the action of ticagrelor?
Yes. It's asking if the dose of aspirin increase will affect the role of ticagrelor or not.
So actually in the Plato trial, right now after the sub-analysis of the group, they do not suggest to use aspirin higher than 100 milligrams per day, because the subgroup analysis demonstrated the high dose aspirin plus ticagrelor only increase the risk of bleeding and could cause
Yes.
an adverse clinical outcome. So right now, if you want to use the DAPT treatment with aspirin ticagrelor, so the recommendation for the dose of aspirin is 100 less than 100 milligrams per day.
Could I have a question?
Thank you very much.
Yeah, please go ahead.
I'm Sohail Aziz from the Rawalpindi Center. You know, when you give, there's no doubt that ticagrelor has a advantage in acute syndromes. So, but taking 2 tablets a day, you know, compliance can become a potential issue, and because it has increased bleeding issues also. So, is there sense in giving this for the first year and then switching to clopidogrel later?
Yeah, you mean just give one year then shift to clopidogrel?
Yes.
Yeah, of course. current guidelines just suggest us the DAPT for the treatment for DAPT for ACS, the standard treatment right now is just 12 months the depth. So usually right now we give patient with aspirin plus ticagrelor usually for 12 months only. So after 1 year, actually we stop ticagrelor and give patient only aspirin monotherapy.
And some people tend to have a lot of dyspnea with this drug.
Yes.
So how much dyspnea have you noticed in your patients? How often does it happen in your experience?
Well, I think that's very tricky. If you that depends on how do you define dyspnea and how do you survey the dyspnea.
Hello.
So if you ask the patient, do you have dyspnea or breathless sensation, many patients will answer yes. However, in my personal experience, there are not too many cases for very severe dyspnea. So usually if a patient do complain have the dyspnea under the ticagrelor treatment, but after examination, there's no other reasons for the dyspnea, and the patient still can tolerate the sensation. We just persuade the patient to keep the treatment. However, if a patient cannot tolerate the sensation, we just change the medication.
And is there any association of solid body tumors with these drugs?
Pardon? The tumor? Or?
Yeah, is there any association of a solid body tumor with these? I remember some data coming out that there was association of solid tumors with these drugs.
Oh, you mean the association with some cancer with the ticagrelor?
Yeah.
Yeah, so far there's no very definite evidence to demonstrate that association. So right now we use the drug very comfortably for our ACS patient.
Yes, questions from Lahore again.
Yeah, my name is Professor Akram. Thank you so much for wonderful talks. Very educative, all three of them, starting from Shahbaz and Dr. ending with Dr. Yi. Just a comment upon what my friend from here said about. I think the high doses of aspirin are not really recommended with Ticagrelor or other P2 vital inhibitors because they affect the metabolism. And the other thing is that we must remember the metabolism of these drugs is primarily the cytochrome P450 system in the liver, hepatic. So in hepatic disease, which is quite rampant, unfortunately, in our country, we have to be careful in dosage. We do not know exactly in our population the outcomes. I don't think there is any study yet in our population. And also because we are slow acetylators as compared to even the countries around us. So I think we must do some studies locally, so we have a local data before we can be confident of its use. Or the loading dose, we don't know whether 60 milligram, 4 tablets together to start with and then de-escalate it. Really, all these studies, the evidence is not from Pakistan, so there is a note of caution that when we use it, we have to go slow. It's better to use it, but it is nevertheless a very, very important drug because we at Pakistan Aspirin Foundation, we are just doing a A4P study, which is on aspirin and primary prevention in Pakistani population, 49,000 patients. We are seeing a lot of aspirin resistance, unfortunately, in Pakistanis. Half of it is dose related, but the other half doesn't matter whether you keep on increasing the dose. Similarly, we are seeing a lot of clopidogrel resistance in Pakistanis. So obviously, we need agents where these things are not present, whether prasugrel or Ticagrelor. But I think I'll re-emphasize to my colleagues over here, very learned colleagues are sitting here, that we need to set up a local study, whether we do it under Pakistan Aspirin Foundation or Pakistan Society of Internal Medicine or Pakistan Cardiac Society, or we can all get together and frame a protocol that will be very, very important. And I think the companies who are bringing in newer agents must also realize the need for local data because Pakistan is a huge country of 220 million, and we cannot be relying any further on data which is reported and not in our population. Thank you so much.
Thanks for the fantastic comments. There's one question from the audience. Mansoor Ahmad is asking, Prof. Lee, can you make some comments on the subset of patients with AF using DAPT?
Right now, if the patient have atrial fibrillation, usually we do not use the depth. So if the patient with the ACS and the atrial fibrillation, so usually if the coronary lesion is not too complicated, right now the standard treatment right now is a NOAC plus the clopidogrel. It's a dual therapy. However, if those patients with more complex coronary lesion, we still use the triple therapy with the depth plus the NOAC. However, the duration of the depth, that is the duration of the aspirin, right now is very, very short in the patient with AF plus ACS or AF plus PCI. That depends on the intervention cardiologist. They have different point of view. Some usually, basically, if you want to use the triple therapy, usually right now the duration for the aspirin is only maybe from 1 week to 1 month.
Thanks, Prof. Lee. And to emphasize the DAPT that he was mentioning about is using clopidogrel and not prasugrel or ticagrelor together with a NOAC. I think we need to move on to the finishing lecture by Dr. Akhter Ali on sharing Pakistan's experience in use of ticagrelor and other agents. Can we have the last lecture, please? Dr. Akhter Ali. I'm sorry, but am I seeing Dr. Akhter Ali's phone screen for our last lecture, please?
Yes. He's going to share by his mobile phone. Please rotate 90 degrees so that we can see a larger screen. Thank you.
Thank you very much. Maybe you can unmute yourself as well. Dr. Ali, could you unmute yourself? Dr. Ali, if you have problems, maybe you can just speak to us without the slides. Are you able to do that? Are you currently unmuted?
Yes. Hello.
Yes, Dr. Ali. Are you able to speak to your slides without sharing it? Because I think it'll be difficult to share.
Yes, actually, Yes, actually, I'm sharing it from my iPhone because I was on vacation. So I have joined from a far off place. So I could not reach Rawalpindi with my colleagues. Can you hear me now?
Yes, we can. Maybe you try it.
Yes. Can you see my slides as well?
Not well. It keep flipping up and down. So I would request that you stop share and just speak to us on your lecture, please.
Okay. Okay. So this is about the initial and long-term treatment of management of acute coronary syndrome. And we know that antiplatelet therapy is an important aspect of management of the acute coronary syndrome, including statins and ACE inhibitors and all that. But prasugrel, clopidogrel, along with the aspirin, has been traditionally used from a very long time. In Pakistan, we started using prasugrel first, and ticagrelor came later, actually. If you are unable to see my slides, can I try to see it again? One more try to see the slide. No,
I think it will be difficult, Dr. Akhter. I would suggest maybe we have a discussion. Can I ask you some questions then?
Yes, why not?
Can you share with us, you said that Pakistan started with use of prasugrel over clopidogrel for ACS. Currently,
Yes.
Is it still the current practice to use prasugrel over?
We are using prasugrel very less, actually, because once we started using it in 7-8 years ago, there were more bleeding in our patients in acute coronary syndrome, and so we had a better experience with clopidogrel. So later on, ticagrelor has come in last 2-3 years, and we have started using more, and it is more safer drug, actually, what we have seen in our patients regarding the bleeding.
Can I ask a little bit more about the bleeding observation? When you say bleeding, you're referring to BAC3 transfusion requiring bleeding and above, or what type of bleeding?
Yes, in prasugrel we had bleeding with definitely it was not most of the time it was not needing any transfusion, actually, but we had to stop this prasugrel and shift the patient back on clopidogrel because it was most of the time it was acute coronary syndrome patients who were stented and the stenting we either had to shift to the single antiplatelet or we had to add a clopidogrel, which resulted in a better outcome afterwards. They did not had major bleedings again, actually, but this was the experience with which we started using prasugrel less frequently in our acute coronary syndrome patients.
So can I ask the rest of the chairs and panel, is this the same observation that you have increased rate of major bleeding after use of prasugrel over clopidogrel for ACS? Maybe we can get some comments from Lahore.
I think prasugrel was available here for. Okay, it was available, yes, for but a short while, maybe a couple of years or so. And prasugrel I personally used mainly because of restriction of use of over 75, underweights, below 60 kgs, and so on. So it was used, and as soon as the data came in about ticagrelor, the prasugrel use actually went down by then. But I still found it useful because in certain patients who had thrombocytopenia with clopidogrel and with prasugrel, I didn't find thrombocytopenia. It was useful, but I think based on the study that came out with ticagrelor, prasugrel went out. Otherwise, the use of prasugrel, when I used it, I did not find any significant difference in bleeding as such. But of course, it's my personal and it cannot be classified as I study or something. But prasugrel did not last very long.
Thanks for those comments. From Lahore, any comments?
We don't have any history data showing that there's more bleeding with ticagrelor versus clopidogrel, but observation, yes, it does cause about 80-85% inhibition versus you're getting 50-something inhibition clopidogrel. You do get more bleeding with that's what people have observed in anecdotal experiences. But I think the key thing, as it was pointed out in previous presentations, as well as judicious use. And that concept of no increase in major bleeding, that message from the PEGASUS trial, I think should be kept in mind. That goes for both CABG, non-CABG patients. CABG patients, the bleeding did go up. So in the elderly and frail patients, low body weight patients, those you should be in with the patients high. As blood score is high, you should be cautious with the ticagrelor use. As the popular age trial also showed that the bleeding goes up. It was for patients 17 above. But for all the other patients, we declare mortality benefit, stent thrombosis is less, and all the endpoints are good. So, it is underused because of the bleeding concern, but which is not as much there as people fear it. But just your thoughts and comments on the dyspnea thing that was discussed before. It was about 13% in the PEGASUS trial, and from what I remember, with Plavix also, it was 8% dyspnea reported because everybody was being asked in the trial to give dyspnea on follow-up. So, but 1 in 10 had to stop it because of dyspnea in PEGASUS trial. ISORAC 5, the incidence was even higher than that. And in practice also, I'm seeing that I have to, in 1 in 5 patients, deal with that dyspnea thing with ticagrelor, and I switch over to clopidogrel. It is better. It's actually more than 1 in 10 that was seen in the study, PEGASUS trial. Then in practice, I see that. I don't know why over here I've seen more dyspnea. So, and this persists. You thought that a few weeks and it will go away, but in some people, they just, and I changed the drug, it felt better. So I don't know your thoughts on that dyspnea thing. That the adenosine effect will go away and it won't bother them much. But I've had to stop it in almost 1 in 5 patients in clinical, my personal experience.
Another comment actually. As we have noticed that ticagrelor as platelet inhibition is reversible, whereas is not reversible with other drugs. The food for thought. Many of our patients may be non-compliant, and many people would think that missing a single dose is probably not so significant. So, what would you say? Anybody and the speakers or panelists really? What about missing the dose of ticagrelor versus clopidogrel or prasugrel? What are the chances of stent thrombosis in say, within a week or a month after stenting? Any comments?
I think it's quite tempting to say that we can consider it as a single-day use, but based on the half-life profile, is not recommended. And I think that is one reason, if I look at the ISO-REACT 5 study, showing that prasugrel is slightly more efficacious, because on follow-up, half of the patients do not refill their prescription for ticagrelor for precisely the same reason, for compliance. I think a lot of patients default a BD dose therapy. And I think that is one reason why it's not demonstrated in real life as efficacious. So I would not advocate using ticagrelor as an OM dose, and missing doses regularly is not a good idea for a drug like ticagrelor. I think that's why an OM dose therapy like clopidogrel or prasugrel does have compliance benefits.
Thank you for the comments. This is what I was expecting, and I do have some reservations using ticagrelor because compliance is a very, very big issue in our part of the world. It's a very big issue.
It's a big issue everywhere, so it's not peculiar to Pakistan. So any other comments or questions from Prof Lee, Upendra, or anyone before we close?
Well, what about the non-responders to clopidogrel? Would you directly switch them over to ticagrelor? There was a study by the name of onset and upset study. And in that, it was shown that people who are non-responders to clopidogrel, especially this is a big percentage, say 1 in 4% people will be non-responders to clopidogrel.
So maybe I can make some comments here because it was brought out a few times in this symposium, and maybe Prof Lee can chip in. In Asia, it's not just peculiar to Pakistan, in Asia, in Chinese populations, East Asia, either aspirin or clopidogrel resistance rates is very high in vivio. Up to 2/3 of population could be potentially resistant to either clopidogrel due to the heterogeneity of CYP2Y12 genetic variants. But we haven't translated this to outcome difference. And in most of the trials, it's not been demonstrated that this kind of strategy works either as an escalation or de-escalation strategy, actually. So short of having an outcome study, I'm not too certain we can advocate using the responsiveness or genetic studies to guide therapy at the moment. I think I'll advise against that. I think the clinical scenario is probably more useful based on guidelines as usual. So if you do have ACS, STEMIs, I think a 3rd generation tirupyridine, either prasugrel or ticagrelor, is superior to clopidogrel strategy. If you do have concerns and you do check for non-responsive, for example, a high-risk stent anatomy or ACS, and you want to consider escalation, I think it's also possible. There are trials and smaller studies to say that they use that to guide when to go in for surgery. For example, if you checked it and then they have no longer become effective, then surgery have less bleeding when you do going for surgery. But I think as a de-escalation or escalation strategy, I wouldn't advocate that. Any comments on Prof Lee on this part?
Yeah. Yes. In Taiwan, we don't routinely perform platelet function test or do the genetic screening. So we just like Jack said that. Yeah, right. Agree with you.
Any last comment, sorry, from Lahore?
One thing I would like to add is the drug interactions of ticagrelor, especially with antifungals, with redoxin. So what are your views about this? The drug interactions.
Drug interaction with ticagrelor, is that correct?
Yeah, ticagrelor, one should be careful if the patient is on any antifungal drugs or redoxin drugs like this. Thank you.
Prof Lee, you want to have a go at that?
Reminder on that is that anything which affects the CYP system, cytochrome P450 system, which includes antifungal, antiviral, seizure drugs, just be careful in adjusting the dose for that. But like you would with any other drug that you're using, that you should be watching on drug infections. There's an interesting experience that I wanted to just share over here. I moved back from US about 2 years ago, and over here I saw a routine thing being done that clopidogrel is being used twice daily. I haven't seen any good trial data to support it, but somehow the once a day clopidogrel use, they were seeing more stent thrombosis. There's no registry data, but that was the experience. So everybody generally uses clopidogrel twice daily. I never did that in US. But I do that because of the local trend and practice, and I think all the people who have moved from abroad also to change the practice that they use this twice daily. I guess question is, in all the trials, the Taylor trial, the Trident trial, they compared once a day Plavix dose with this. If you're using twice a day Plavix for the first month or first few weeks, would you, in terms of comparison, and you guys do it in Taiwan or anywhere else, a twice a day dosing of clopidogrel?
Actually, I do see that practice once in a while for twice daily clopidogrel for initially before the 3rd generation tirupyridines came out. It was a reaction to the concern of either resistance or efficacy for stent thrombosis. So it was written out of fear rather than evidence. And some of the folks in the US do a POC to check for resistance and then switch to a BD therapy and then recheck. So I would say that in this current day and age, in terms of drug interaction, Ticagrelor, because it's an independent pathway, has less interaction compared to a cytochrome P450 dependent system like clopidogrel. So if you ask me about drug interaction, there are more in clopidogrel than Ticagrelor by far. I think in terms of efficacy, I think there's no doubt Ticagrelor efficacy is high. A little bit of comments about the dyspnea question that keep coming up. In the published study, the percentage difference is significant, but the absolute is not as if the clopidogrel group did not have dyspnea. Initially, when we first started using it in Singapore, we do have a subset with complaint of dyspnea, we're more concerned. But since then, we have widespread use of Ticagrelor. I don't seem to have this complaint anymore manifest actually. So in my mind, the dyspnea piece is not a huge concern. And I don't see it in clinical practice as much as what was expressed. Maybe it's a...
Hello, I'm Professor Javed Akram from Lahore, and first of all, wonderful four talks, actually 3 talks, and then all the speakers, they were wonderful. Regarding the use of this Ticagrelor, and on my experience, obviously still clopidogrel is doing great here in Pakistan. But there are a few situations where definitely, obviously, I will recommend that Ticagrelor should be there as a first line. First is the STEMI patients for the primary PCI because of its rapid onset of action as compared to clopidogrel. It's always better to start with the Ticagrelor. The second is the patients coming with subacute or acute stent thrombosis, patients who are on clopidogrel and aspirin. Obviously, it's my advice to all my colleagues that you have to switch to Ticagrelor immediately and don't try clopidogrel at all. Again, if you have got a case of a stent thrombosis, and obviously if it's not because of a procedural factor, stent malapposition or whatsoever, so you have to. The third sort of a patients where I always prefer Ticagrelor is left vein stenting or the ostial LEDs or a complex bifurcations involving distal left mains, etc. They are always, I would prefer using this Ticagrelor with this. Regarding and the fourth set of the patients where I prefer is the high-risk patients, multivessel stentings with bad LVs. Obviously, these are the cases where I prefer Ticagrelor on clopidogrel. The rest of the simple PCIs, and clopidogrel is doing good. Elective PCIs, it's doing good. But obviously, we have to look at the bleeding risk whenever using Ticagrelor. Regarding the dyspnea factor, as Professor Upendra was telling you, it becomes sometimes difficult to know whether it's dyspnea of cardiac origin or because of Ticagrelor, especially if you have got a normal ejection fraction on echocardiography. I always go for NT-proBNP testing before I decide whether it's, so many of our patients, they are found to be suffering from diastolic failure. And, if you have got a normal NT-proBNP, then obviously you can always take off Ticagrelor during this, dyspnea sort of a problem with normal ejection fractions. But if there is NT-proBNP is elevated markedly, you always think of a diastolic failure also that may be contributing. And if it still persists with diuretics, etc., then obviously you can switch to clopidogrel. Thank you.
Excellent comments. Yeah, excellent comments. And I agree with all the points that you raised, except for the caveat to say that if you do want to use it for the high PCI risk group, I think the initial intervention done well does help a lot. And I do agree that the BD dosing is an issue for compliance, but it's a great drug when you're using it in the acute ACS, especially STEMI situation, because of the very rapid onset compared to clopidogrel. But subsequently, I think it's also, if there's a cost consideration, not a bad idea to titrate down to a DAPT therapy with clopidogrel, but you do have to reload the clopidogrel. And I think the duration of switching should be about a month to 3 months. I think that's reasonable. Regarding the bleeding risk piece, if there is a concern about bleeding risk, you have to consider a strategy of shortening the DAPT rather than comparing between agents, because the subgroup with high bleeding rates will bleed regardless of whether it's clopidogrel or ticagrelor in general. So a shortened DAPT regime helps more than considering whether it's a Tica or clopidogrel or prasugrel. I think just to take note of that. So I think we've come to 2 hours. Actually, I think I enjoyed myself listening to all the talks. I'm afraid we do have to close out at 2 hours, and I'd like to thank the speakers, the panelists, the chairs for allowing us a chance to do a 3-city symposium simultaneously. I'd like to again to thank our hosts, TSOC, APSC Cloud, for facilitating this session, and the attendants and the chairs for making their wonderful comments. So with that, I'd like to thank everyone for their time tonight. Please do keep safe during this COVID-19 pandemic, and we do hope to see everyone very soon. Thank you very much, guys, and goodbye.
Yes, sir, please.
Assalamu alaikum. Thank you very much for your presence. We have an eminent faculty over here. The participation was excellent. I really appreciate High Noon for creating and collaborating with this platform at which we were part of Asia Pacific Cardiac Society meeting. And whenever a new molecule that comes over, I think this was an excellent timing that we had this molecule in use for about a year or so. We have a local experience. It was a good time to share what other countries are facing, what are their experience. And I think Professor Javed Akram pointed out great that unless we have our own data over here, it's really hard to press upon the need of a new molecule. But of course, since the new technologies are coming out, we need to have a judicious use based on our experience. High-risk patients, high-risk bleeding, which is a better molecule? Especially in non-STEMI or STEMI patients, when really the ischemic burden is high, it's a good idea to use this medication, which can be tapered down in about a month or 3 months based on your own experience, because we don't have much data to clopidogrel OD to be taken upon from that point of view. Of course, with a new molecule, cost becomes an issue. And if you see from the other side of the point, whenever a new molecule comes, the cost is high for the other company as well to bring this molecule. We want to encourage having options for our patients who have, unfortunately, either resistance to the older molecules, efficacy-wise, and once you have an evidence of failure, if you don't have other tools with you to play with for your patient, then it becomes a big challenge to take care of those patients. I really appreciate your presence and attendance here, and we know it's getting really late. I would request our chairperson to kindly come on the stage, and we would give mementos to our participants who have taken part in the program. Thank you very much.